Hey friends, David Rice, chief editor from Dentistry IQ, back with my partner in crime this week. What's
Hey,
happening?
I'm Pam Maragliano Muniz, Chief Editor for Dental Economics. It's been a week.
It's been a week, and I think we've got some unmasking. Oh my God, asking that could have gone sideways in a hurry, but got some dental unmasking to do today with two great guests. So, Brandon Walker, Alex Vasserman, welcome.
Hi,
Thanks
thank
for
you.
having me.
So, our initial conversation, David and I have had this conversation. We've had this conversation with other people as well. Do you really have to rubber dam? And if so, you know, I know, you guys are kind of, in different camps here. Brandon, do you really rubber dam every single patient, or are there some that are just, better than others? I mean, I don't know. I personally, for me, I love the concept of rubber damming. And when I rubber dam my patient, I always feel like I'm doing better or more or something for them. And I'm always super excited. Usually I'm excited about it. But I've put a rubber dam on somebody and they had an anxiety attack. And I was like, friggin' A, man. And I took it off and then didn't rubber dam. And then there's times when I've rubber dammed a third molar and I felt like the best badass out there. And then the guy's been complaining about his TMJ ever since. And I'm like, I don't know. So I feel like I am a fair weather rubber dammer. And so I like isolation devices, but I do love the rubber dam. So I'm going to just kind of let you guys unleash your opinions. So Brandon, let's start with you. I see you kind of grinning. I can tell the judgment. You guys, he's judging me because I'm a fair weather rubber dammer.
Hey, I'm
Pointing.
excited that you use Rubber Dam actually. I come from University of Washington, which is a huge rubber dam school. Everything that we did in clinic during training was all rubber dam. It didn't matter if you were prepping or restoring, you had a rubber dam on. And so I know other schools are different. Other schools aren't as strict as that. So I think it really depends on where you're brought up, and that develops your habits early on. It also develops some of that early skill set and some of that early lines of thinking. For me, I always approach dentistry in the way that how would I want it to be done? If I was the patient having dentistry done on me, would I want the best dentistry, the best restorative, the best isolation? I call it rubber dam absolute isolation for many reasons, and I can talk about that. But I want a rubber dam on my face when I'm having restorative done, especially if it's adhesive dentistry. So that's my stance.
Yeah. Alex, where do you sit on
Yeah,
all this?
Pamela, I'm very close to where you stand. I probably rubber dam 60% of my cases, but there's certain cases where I need something else because I just either can't rubber dam, or in my hands, the rubber dam is really hard to put on, whether there's bridge work in the area or pretty subgingival situation, or I just can't numb the patient in order to put all the clamps on, or I have a temporary assistant that doesn't know my routine in placing a rubber dam. I sometimes rotate assistants. So in that situation, I will use something like the dry shield, where it's got a bite block. I can retract. It's much better than just like cotton rolls and saliva ejectors. But you're right, it's not for adhesive procedures. I agree with you, Brandon. It's not as good as a rubber dam, but I think it's the second best. And for some procedures like putting attachments on, or if I'm restoring an implant and I'm afraid for the little pieces to go in, I'll put a dry shield in because I rather a little screw get suctioned into the dry shield versus going down the back of the throat. So there's there's a lot of uses for it.
I agree with that. And I think you'll appreciate this, Alex. Back in the day, before dry shield was even a thing, I remember thinking it would be so cool to invent something that would prevent things from falling in the back of your patient's throat. And I thought the perfect name for it would be the goalie.
Oh, And I used to be the goalie in high school hockey. So there you
I
go.
was a goalie too.
Wait, we've
What?
got 2 goalies on here?
And
Oh
we're
my
from
gosh.
similar. We were neighbors to Salem, Massachusetts, Marblehead, Massachusetts. So.
Who's got implants for their anterior teeth?
I'll never tell.
Oh my
No,
God.
I think Alex makes a good point. You have to have a lot of different tools, you know, in your armamentarium. And, you know, I use IsoLite or IsoVac occasionally. And I find that there's similar challenges to getting the patient to adapt to every single device that we use. The rubber dam can be really challenging at first, but walking the patient through it really delicately and having them do breathing techniques and that sort of thing works well. The same is true for IsoLite or IsoVac, where you're shoving this whole huge piece of plastic in them. I tell them they're going to go snorkeling for a little while. And, you know, that can gag them having the plastic way in the back. But it does give you good cheek and tongue retraction. The problem that I usually have with some of these conversations is that people will call, you know, cotton rolls isolation, or they'll call IsoVac isolation. And it's like, what kind of isolation are we talking about? Are we isolating the field, or are we isolating moisture? To me, in adhesive dentistry, there's no other option but to isolate absolutely for moisture and the field. And I think that's where you're going to get your prolonged clinical outcomes and better results. There's studies that show this. In fact, this study came out in 2022. You guys all know Professor Blatz and his team. They put a fantastic study out that's called Clinical In-Situ Evaluation of the Effect of Rubber Dam Isolation on Bond Strength to Enamel. They made custom splints that went up on the palate, and they implanted basically an extracted tooth, you know, in the splint. They bonded to it with and without rubber dam, and they found that with rubber dam, the bond strengths were higher. They also had failures that were cohesive instead of adhesive compared to without rubber dam. So I think that that's a situation that a lot of clinicians maybe overlook, because they don't think of the breath and the vapors as moisture. They think of saliva and they think of heme and other things as things that they just have to isolate with cotton roll. But the patient is alive and breathing, and the breathing alone has a huge impact on your adhesive dentistry.
So I wonder if they could maybe do a study where they compare the same thing, rubber dam, to something like a dry shield or an IsoVac, where it's blocking a lot. I agree, for adhesive dentistry, you know, onlays, inlays, composite, rubber dam is the standard of care. But I would love to see a study where they compare a dry shield or like a IsoVac to a rubber dam, just to see what the difference would be, strictly for, you know, scholarly purposes.
Sure. I mean, I think the big point in this study, though, was just breath vapor, right? Moisture from the breathing. And with dry shield, and especially with IsoLite or IsoVac, when you have that vacuum on, it's spinning. It's sucking saliva, but it's just spinning around moisture in there. And so, you know, I agree. I think it'd be interesting to have a study like that. I think you'd find probably worse results because there is a significant amount of moisture just being spun around, especially when you're using like an IsoVac.
That's interesting. We'll have to check with Nate. We were talking to Nate Lawson not all that long ago. There actually are studies, and some of them show that the dry shields of the world compete well, and in some of those studies they outperform a rubber dam. So I'll have to get a hold of him to see what that is, because that was surprising to me. We had that, right, Pam?
We did. We talked about the humidity.
I was shocked.
In the mouth, and the fact that dry shield or dry shield like devices will reduce humidity in the mouth, where the rubber dam doesn't. The other thing about rubber dam, and I don't mean to again dog on my friend rubber dam, because I do love it, is like a rubber dam, if it's not done properly, is almost like not having a rubber dam, right? Like I would say, if you know, you start to see leakage through your rubber dam, or you know, you're popping the holes and they're too big or whatever, that's not the same. Like, you're going through the motions, but you're not actually getting the benefit from the rubber dam.
It's a good
Yeah,
point.
I agree. I think that my friend, when I was in the Marines, he used to joke, he's a Youper from Upper Michigan. And we were joking about training. We were doing radio training, and people just couldn't pick up the concepts of how to use a radio. And Dave would say, the first thing you do when you get something new is you take the manual, like a new car, you take the manual and you sit on the toilet and you sit there for an hour or two and you read the whole manual all the way through. The interesting thing about people is that, you'll get a new iPhone or a new Android phone or whatever it is you use, or an iPad or computer. You'll sit down and you'll learn to use it really fast because you have the interest in doing it. But I hear a lot of people say with rubber dam, that doesn't work well in my hands. I can't get it on fast enough, that sort of thing. And I think that if we took that approach of sitting down and just learning and experimenting how to do it well, and then especially training the team to do it well, then you can have a lot better outcomes. I tend to punch my own rubber dams myself. I'm just anal in that way. But I also have a couple staff members who love doing it and they do it really well. So
It's a good point too. I think I punched a few walls placing rubber dams over the years, but no, that's a really great point, Brandon. And it takes time. It takes time, I think, for us to master it as dentists. And then it takes time to train our team, for everything that we do, but especially something where for a few decades, we've found 101 reasons why not to do it instead of finding a reason to do it. Hence a lot of the devices that are out there. But I will tell you, in our practice, we run triple hygiene every single day. So for us, isolation's not just on my side of the practice, but it's on that hygiene side. And, you see so many stories out there about sealants are awful. Well, no, good sealants are fantastic. It's just most people can't place them for some of the reasons we're talking about today, and then lots of other ones as well. But that's a great example in our practice where, our hygiene team, not just for sealants, but just even for doing quads, they take that GV Black convenience form thing and let's just hold all the stuff out of the way and let me do my job. So I don't know, Pam, like where are you using all the things that we're talking about?
All the places, basically. Yeah. So we use high-speed evacuation in the hygiene room. And so obviously we've got a dry shield device. We've got, aerosol assist and PureVac HVE. And basically it's whatever that hygienist needs and wants on that specific patient. And so I find there's people that love one device over another. There's obviously clinicians who like one device over another. So in hygiene, they're using some sort of high-speed evacuation, but for what it's really depending on that patient. For me, what's that?
Oh, sorry. In our building on that, in our practice, we use the EMS machine, which is the powder and for that, the dry shield works so well. First, we do one side of the mouth and then the other, and it just removes all the aerosol, and it's great.
Oh my gosh, that's the airflow prophylaxis master. Yes.
Yeah, it's great.
I just bought my third one. It's in a pile of boxes in the front of my office. So they're fantastic.
That's where all new things go.
Yes. Well, they haven't been taken out of the boxes yet. Like it literally just got here today. So
you're okay.
Out of the box. Yeah, no, it's coming out. I promise.
You goalied it.
I did. Yes. So so for hygiene, absolutely. And at least for me, and like for restorative, I feel like you have to do something. And it's actually funny. We tried to get somebody on here that was willing to admit that they're a cotton roll dentist, and we could not find anybody that would come on here and be like, yeah, man, cotton roll's where it's at. We certainly couldn't find that. Hopefully it is because everybody's doing something better than nothing. I unfortunately doubt that's the case. It's just that they don't want to get up here and admit it. But yeah, I mean, I agree.
Do we need to name drop?
It'd be a huge list, wouldn't it? It'd be a giant list.
It would be a good size list.
We could just read it for the last 18 minutes. It probably would take us that long.
Well, I remember seeing a post on Instagram, and I will name drop. It was Brian Bollywas, and he was saying he knew somebody, or he had assistants that could pack cotton rolls around a quadrant so well that it would just keep it so dry and so clean for the duration of whatever they were doing. And my comment to that was, that's cool. Can you put that energy into placing a really good rubber dam? Because if you can't put the energy or the time into doing a rubber dam really well, especially, and I'm mostly talking with adhesive dentistry, especially if you're doing adhesive dentistry, then why as a patient would I trust you to do adhesive dentistry on me? I mean, adhesive dentistry is complex and it's extremely technique sensitive. And there's cases, and I just luted, a crown just the other day, and I used Isovac to do that because on some patients, the hygiene is pretty bad. It's sub G, they come back and the gingiva is all inflamed. And sometimes you just have to elute it and go with that on those types of patients. But I think in general, if you can focus energy and time into doing something really well, then I think that you should do the standard for what it is that you're doing. And with adhesive dentistry, that would be rubber dam. With adhesive dentistry, you have enamel bonding, and that study that I mentioned just focuses on enamel bonding. But what about dentin bonding when you're bonding to dentin, and what do those outcomes look like? Because bonding to dentin can be twice as strong as bonding to enamel, but it's more technique sensitive, and you need a very, very dry field to work in. So I guess it just really depends on what you're doing and how you're practicing. I love the rubber dam because I can put it on, especially if I'm doing a quadrant. It gives me a clean surgical field. It gives me improved vision. I'm not sponsored by these guys or anything, but I love the Nictone rubber dams. They're thick and they're latex.
That's the one I use. Yeah, it's great.
Yeah, they're awesome. They have thin, medium, and thick. And so if you use a thicker rubber dam, you can get more tissue compression and better access, especially on deeper cases. But the light blue is phenomenal because it's just really, really, really nice on the eyes versus some of those greens and pinks and other colors. If you're working for an hour or two and you're staring at that, for me, at least it hurts my eyes, which takes me to ergonomics. If you have the whole field opened up and the cheeks are retracted and the tongue's out of the way, you don't have to worry about the patient aspirating anything. And you can just work there and you don't really have to do any heavy mirror retraction, which screws up my neck and shoulder all day long. And I've only been in practice 3 years. I'm surprised that, Dave, you still stand and walk around like a normal guy. But the assistants love it. The assistants at first, when I've had assistants, they've been a little bit like, I don't want to do that. I don't know how to do that. I'm like, focus, let's do it. I'll teach you. They start doing it and they're like, my job is so much easier. I actually love assisting for restorative now because they don't have to do all that retraction and fighting the tongue and all that other stuff.
It's nice, just like with the rubber dam and the dry shield, almost like frees their hands up to get the bonding agent, to get the Unisam, to get the stuff, so they're not like holding, quickly, like reaching. Oh, it's great. So with dry, like when we're doing, like we're putting buttons on for Invisalign, and because the dry shield's there, when we're putting it on, they can now get the edge. They could cure. They could use actually 2 curing lights to double the speed, which is nice because the dry shield is like holding everything apart. So for like putting attachments on, or even when I'm like extracting a tooth and it's a surgical extraction, I'll put a dry shield in, and now they're free to retract, to suction, to get the saline, to get the gauze, to get the bone graft, whatever it is, and the dry shield's keeping everything. The other day, it was funny. I was restoring an implant and a little piece fell and the dry shield caught it and suctioned it into the suction. And I'm like, thank God, it's so much easier to get it from the filter than to hit the patient in the back of the, hopefully that it pops out,
Oh my
So-
No,
gosh.
that's awesome that you're using it for attachments, because I know a lot of people will just place those clear aligner templates in there with nothing,
Yeah.
and that
We
it's a
cut
real
them
pain.
Yeah, we cut them into thirds so I could maneuver it around the dry shield, and then we just cure it. And then when you got two top and bottom and everything's retracted, we use 2 curing lights, or even sometimes 3 curing lights if someone's free. And I got 2 curing lights and someone's got it, and we can hit all the buttons in like, a few minutes, the whole quadrant's done.
Double fisting. I think that is fantastic.
Hockey players, come on.
So, oh my gosh, so many. Okay, so a couple thoughts here. Number one, I just got back from spending some time with 3M, and I learned something so interesting about attachments and clear aligners. Now, I might be late to the game, and you guys might be rolling your eyes and being like, lady, we've known this forever. However, did you know that flash around the attachment can displace your aligner to the point at which it will reduce the efficacy of your planned clear aligner therapy and increase your chances for needing refinements later?
Yeah.
But did they give you percentages by chance?
No, I asked for how much displacement and what that would look like, but no. But I think that's really interesting. So if you are providing clear aligner therapy and you realize that, you kind of are going into it telling your patients that they're going to need refinements, and you have your assistants placing attachments, and you notice a bunch of flash there, that can totally change your orthodontic outcomes, not for the better. So
I see patients come back, because I do Invisalign. I see patients who come in for hygiene, and they're in clear aligner therapy with orthodontists, and they're a mess. Their attachments are a total mess. And it's because most of the time it's just auxiliaries, slapping those on. I learned going through a couple Invisalign courses about what you just said about the flash and the implications of that. And yes, you have huge problems with having to do refinements, a lot of refinements usually. And it only takes a little bit of time to go in there with a good set of loops. A good tip that people are using is a black light flashlight to highlight the flash. And you can either go around with a 12 blade, or you can go around just with like a really fine carbide to kind of just chip away at that flash, because it will impact how the clear aligner attaches and engages with those attachments.
Pam, it's been a minute since we've used this phrase, but we used it a while back: slow down to speed up. And I think if we invested more time as clinicians on the front end of isolating properly, of doing the procedures properly, we would find that we saved not only hours of our time, but think of the hours just on this one topic. Think of the hours in a patient's life that get wasted with wearing aligners 22 hours a day, because we scream at them and tell them to do that. And then they need 3 refinements, when probably you could argue beyond the diagnostic process that if we had the proper clearance interproximally, because we usually underestimate that, and we actually did have great access so we could clean up all the flash, like how much time we would save, headaches, and the predictability we would gain is immense.
Oh my gosh, so much. So yeah. I want to go back for a second, because I think this is important. I know we rubber damned everybody at Tufts in dental school. And I feel like you got to the point where it wasn't even up for debate. Like I never had I don't remember. I know it was a while ago, but I don't remember patients being like, no, I can't have that. And me being like, okay, like that never happened. And so everybody was rubber dam, like for all of the things that we did. And I feel like as a dental student, you get so used to it, obviously, because you don't have an assistant, you're rubber damming by yourself. You've never been better at placing the rubber dam than you are as a dental student or a new grad. And so if I'm hearing you correctly, Brandon, many of us go into associateships and we're sort of trying to merge onto the highway, into the practice that we have. Oftentimes the practice owner is like a mentor, and you sort of do things the way they do them. So if you end up as a new associate for Dr. Cotton Roll, you're probably going to dabble in the land of a cotton roll, right? And I think that it's interesting because it sounds to me like you, as a relatively new grad, went into it with the confidence of, I know this is the best. I'm going to transform the practice I'm in to accommodate what I know and what the science supports. And therefore, I'm going to isolate, with the rubber dam, ideally on everybody. And if not, I'll use an alternate method. But I think there's something to be said about, there's so many people who want to abandon what they learned in dental school because of the real world. And yet you've taken the best from dental school and you've applied it to your everyday practice. I think that's really awesome.
Yeah, I do too. So tips for young dentists to do that.
It can be challenging, and luckily I haven't had too much pushback. I think here in the Seattle area, rubber dam is used, maybe not for everything, but it's common and it's common discussion. I think a lot of the dentists that are here probably went to University of Washington. The last 2 years as an associate, when I first showed up and started doing rubber dam, the owner was like, hey, we need to talk about rubber dam and what we're going to tell patients, because they're going to be wondering, why does Dr. Walker do rubber dam, but maybe the other doctor doesn't? And I said, well, I don't know what that conversation would look like, but I'm going to keep doing rubber dam regardless of what happens in that discussion. And about 2 months later, she was doing rubber dam too for every single restorative case. And so, I think that once you start doing it, like I said earlier, once you start doing it and the whole team recognizes all of the benefits of it, from the clean surgical field, improved vision, ergonomics, moisture control, gingival retraction, everything else, I don't think it's hard. I think that it's just as hard as any transition. You guys have had scanners and milling machines and other things that you've had to, train staff on. And everybody has their own priorities and everybody has their own interests on what they're, oh yeah, that's going to be useful or that isn't. And then you always have that one staff member that's resistant to everything, right? But when they can see in their own, at the end of the day, when their wrist or their shoulder isn't hurting, or when we're not yelling at them to hurry up because a bunch of heme is piling around the tooth and we need that micro brush now, I think that a lot of them get on board pretty quickly. I'm fortunate now in the associateship that I'm in. I actually work with a long-term COIS doctor, and we were just chatting about rubber dam the other day, and I listed out all these benefits, and he just said to me, he said, Brandon, you know what I love about rubber dam? It just keeps shit out of the way. So fair enough.
Fair enough.
Yeah,
enough indeed.
At I went to Boston University, BU, and during the Northeast Regional Boards, the patient to get checked had to go with a rubber dam and take an elevator up to get checked. And it stayed on the whole time in the elevator, going to get checked, come back, and the rubber dam's there, so it stays. It's great. And we all know how to do it without an assistant, but then you get to the real world, and sometimes you have to have like something else in your arsenal. If you can't place it, there's big bridge and you're trying to work around it, or you just, like I said, you can't get the patient numb to put the clamps on for whatever reason,
Alex, do you ever like, if you're doing a quad or you're doing a crown prep, do you ever just, I think it's fair to prep first. And then if you have to do, an adhesive based buildup or something like that, then you can slap on the rubber dam, after you've prepped. I think I've heard a lot of people do that. I do that sometimes. Do you ever do that, Alex?
Well, sometimes I'll do like a split dam if I can't get the rubber dam around. Like I'll do that. But if I'm already doing a split dam, dry shield, I think, for that reason. Cohesive dentistry, if I'm, like, let's say, if I'm just luting or I'm prepping, that's dry shield all the time, right? Because I'm not, but adhesive dentistry, I would say, like I said, 70 to 80% of my adhesive cases are all going to be rubber dam. It's really rare that I won't be able to put in a rubber dam for an adhesive case. Adhesive cases is almost always going to be a rubber dam.
Yeah, I think that's a really important point, because if you look at it, everybody is doing some form of composite dentistry. Right. That's the normal and that's the standard now. You could get away with, without isolation when amalgam was in play. But, when you think about the fact that, like, a huge percentage of the restorative practice is based on those adhesive procedures with composites, especially posterior composites. Why would you do it any other way, especially if it's an insurance-based practice where you can only do it once, and then if you have to redo it, or if it fails within a short period of time, you're, like you said, David, you have to make up for it. You have to do it over again. That's wasted time in production. It's inconvenient for the patient, et cetera, et cetera.
Post-operative sensitivity, like if you get moisture underneath that adhesive restoration, that's post-operative sensitivity. And then,
there's a lot of headaches we can avoid. Guys, I didn't think I could talk about rubber dams for like 5 years, but I think I actually could talk about isolation for 5 years. You guys are awesome. So how do people best get a hold of each one of you? Alex, how do people best reach out to you to follow up?
Email is great. Alex@dralexvasserman.com, DRA, or Instagram, Alex Vasserman, DMD. That's a good way to do it.
How about you, Dissidentist?
I'm on Instagram all the time. So Dissidentist is the username there, or contact@brandonwalkerdds.com. Always happy to share lists of product recommendations, or even studies, that sort of thing, if people are interested. I'm a nerd, so I hang out online all the time.
Awesome. Pam, it's always great to be with you.
Oh my gosh, this just made me so happy. I love talking about isolation way more than I thought I would. So you guys, thank you so much for joining us this week.
Thank you.
Thank you so much.
All right,
Cheers, guys.
everybody. For Dentistry Unmasked, we'll see you guys next week. Cheers.
Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela_Maragliano and at Dental Economics Official.
Or you can check me out at Ignite DDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskedpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.